Good evening, everyone. Welcome to our webinar. My name is Reem Al Khalil. I'm Director of Patient Safety and Risk Management in Riyadh Second Health Cluster, Ministry of Health, and I will be serving you as a moderator today. Today, you'll be hearing a presentation from Dr. Mohammed Abid titled Redesigning Healthcare Systems to Reduce Diagnostic Errors. Dr. Mohammed Hassan Abid is the Regional Patient Experience Head and a Continuous Quality Improvement and Patient Safety Physician Expert at Armed Forces Hospital, Taif Region, Ministry of Defense Health Services. Dr. Abid is a Fellow of the Institute for Healthcare Improvement, a Certified Professional in Patient Safety, and a Certified Professional Patient Experience. He is a graduate of Harvard Medical School's Masters of Healthcare Quality and Safety. Having a wide range of experience in multiple quality improvement and patient safety domains at benchmark institutions in the US, Middle East, and Southeast Asia. Dr. Abid's areas of interest are healthcare leadership, a whole system quality and safety, clinical operating system, and person-centered care. Kindly notice that the questions will be at the end of the session. Please post it in the Q&A icon so our speaker will answer them gladly. Moving along to our session, a warm welcome to Dr. Mohammed Abid to deliver the presentation on this very timely subject. Dr. Mohammed, the floor is yours.
Good evening, and thank you very much, Dr. Reem, for this introduction, and also to the Saudi Patient Safety Center for organizing this webinar on the eve of the World Patient Safety Day 2024. And it is indeed a pleasure to be joining you all from across the globe, and specifically in Saudi Arabia, to discuss this important topic of using some system-based interventions in order to reduce diagnostic errors. So let's move forward without any delay. We'll be discussing in our session about identifying the key components of healthcare systems redesign that enhance diagnostic accuracy and patient safety. We'll also touch base on analyzing an integration of patient experience and technological advancements in the form of artificial intelligence in reducing diagnostic errors. And last but not least, we'll talk about some strategies to implement at system level in order to change and bring changes that will improve diagnostic processes. A brief outline about my session today. We'll talk about some patient stories, discuss diagnostic errors, and have a look around some system redesign, and ultimately ending up with some implementation strategies in the form of take-home messages. So without any delay, let's talk about a patient and probably a common story that may happen to anybody of us who are working in the healthcare systems. A 30 years old, morbidly obese patient who is a mother of 2 children, a sole breadwinner, comes into the hospital for laparoscopic cholecystectomy, which gets complicated by access problems related to obesity, tiny bowel puncture, which was suspected but was not proven. Post-operatively, the patient has been complaining about mild abdominal pain, some nausea and anorexia as some sort of an expected outcome of a surgery. Discharged on 3rd day of post-op and was having some mild abdominal tenderness, which was attributed to the incisional pain that results as a part of the surgical process. 36 hours later, after her discharge, the patient suddenly becomes unresponsive owing to a distended abdomen. She was readmitted with a probable diagnosis of bowel perforation and sepsis. Despite operative intervention, she died 48 hours after her readmission. Usually, the hospitals would, in such scenario, go ahead and perform root cause analysis, which labeled it as an unfortunate incident and primarily linked it to an outcome of a surgical complication, given that the patient has given consent that these outcomes can happen as a result of a surgery. And it concluded that the surgeon had acted in a good faith. The patient's families, they take legal actions and file a malpractice lawsuit, and leading to a secondary investigation. Let's look at what the secondary investigation found. The patient was having the vital signs that revealed a steady increase in temperature and pulse, and slowly decreasing blood pressure. On the morning of discharge, the patient had complained of anorexia to the nursing staff and had refused her breakfast, and her temperature was about 38 degrees Celsius. The patient's surgeon was apparently unaware of these symptoms. These findings, having not discussed his patient with the nursing staff, and ultimately also not referring to the nursing notes, the patient and the patient medical records, the patient was discharged. The verdict from the team who performed the secondary investigation was that these combination of symptoms and findings should have suggested to the physician surgeon that the patient likely had abdominal sepsis. The patient's septic depth was possibly preventable, and the patient died because the surgeon failed to pay attention to the objective signs of evolving infection. The surgeon was responsible and accountable for what had happened. The hospital and the surgeon were found to be culpable for malpractice, and a substantial claim was settled. Let me ask you a question. Is this the end to the whole process? Probably not. We missed the second victim. We missed the healthcare provider's perspective. We missed the surgeon's perspective. Let's look at what the competency committee found on professional investigation on the surgeon. They found that the surgeon was double booked on the day of surgery, on the day of the patient's discharge. The surgeon had also taken extra night calls on the evening prior to the patient's discharge and was awake until 4 a.m. He had only 2 hours of sleep before performing the ward rounds on the day of discharge. And there was also some personal stress related to the surgeon due to him preparing for travel to visit his father, who was recently diagnosed with serious illness, adding a personal stress and time pressure. Also, we uncovered some system factors. There were no policies to escalate the symptoms or patient's concerns or listening to the patients. Nurses didn't collaborate much with the physicians owing to the hierarchy and the gradient. And there was no structured handoff or alert systems present within the system. Keeping all that in mind, let's look at another similar patient story and reflect on it as well. This is Sarah, who is a 35-year-old woman with persistent abdominal pain, have had multiple visits to the primary care and the emergency departments over the past 6 months, has been labeled and diagnosed as irritable bowel syndrome. However, her symptoms get worsened, leading to an emergency surgery. The final diagnosis after the surgery was ovarian cancer at an advanced stage. Possible outcomes for her are really about delayed treatment and reduced survival chances. These things happen. They are true stories. Maybe the names are covered or changed, but they are the part of the reality of today's healthcare systems. And keeping all that in mind, let's reflect for a moment as you and I continue to discuss about diagnostic errors and the system redesign, that how might patient outcomes have been different with a redesigned healthcare system? You know, for someone who is a family member or someone who is a patient who have suffered from a medical error or a diagnostic error, they are often left with 2 words, if only. In other words, we can say, what if? What if the system had checkpoints in place which could have alerted the surgeon to take or make the right decisions? What if the surgeon was stopped from doing a surgery and he was tired? What if there was a team member to support him? What if we had better referral systems to the primary health care to close the loop of diagnosis and referrals and tests? That could have led to better outcomes in such patients. Potential lessons that you can think about from these stories are related to organizational leadership and the culture of safety, importance of investigation and follow-up, need for better communication between healthcare providers, value of engagement and engagement with the patients in the process of diagnosis, potential use of the AI and technological advancements in order to enhance diagnosis, as well as significance of considering a broader differential diagnosis, not just focusing on what we see as the presentation. Keeping that, let's see what diagnostic errors are. Institute of Medicine in the US published this landmark report on improving diagnosis in healthcare back in 2015. And it defines diagnostic errors as a failure to establish an accurate and timely explanation of patients' health problems, or to communicate those explanations to the patients. So it clearly highlights three very important aspects of diagnosis, which is diagnosis has to be accurate, it has to be timely, and it has to be communicated in an appropriate time. Let's visualize diagnostic errors in the space of medical errors that happen in healthcare. There may be a lot of failures that happen in the diagnostic process. I'll look into what diagnostic processes look like. And there may be some sort of missed and delayed diagnoses and wrong diagnoses as well. However, for us, the most important part of the diagnostic process failures and delayed or missed diagnoses or wrong diagnoses are the ones that actually lead to adverse outcomes. These are the areas and these are the types of diagnostic errors that we want to really prevent because they lead to significant harm to the patients. And it has been mentioned in one of the references recently, Harrison, which is a classical textbook of medicine in the healthcare. According to a survey by the Institute for Healthcare Improvement and National Patient Safety Center Foundation in 2017, the diagnostic errors or misdiagnoses were the leading type of medical errors among the patients who were surveyed. Looking at the burden, the recent studies have concluded that about 800,000 deaths or permanent disability alone within the US occur every year due to the diagnostic errors. In fact, the Institute of Medicine's report that I was already referring to mentions that everyone in a lifetime is likely to experience at least once a diagnostic error. But the outcomes may or may not be devastating in that. 17% of the patients who experience adverse events in the hospitals are due to diagnostic errors. And 10% of patient deaths can be attributed to diagnostic errors. Now, these estimates are considered a pretty conservative estimates. If you extrapolate them to across the globe, they may be a lot bigger numbers than what we see in these researches and these studies so far. Looking at the impact of diagnostic errors, it's not just the patient harm, it's also very costly. The most common reason or the top 5 allegations among the malpractice lawsuits, according to a malpractice insurance company, Coveris in the US, the top one is diagnostic errors, which is ranging about 40% of the malpractice lawsuits. At the same time, about $100 billion or more gets wasted in the healthcare systems due to inefficiencies in the diagnostic processes or wrong or delayed diagnoses or diagnostic errors. Looking at the diagnostic errors, there is a huge misconception among the healthcare colleagues that usually we would misdiagnose or wait or a diagnosis will be delayed or maybe wrong in the cases of very rare diseases. Well, that's not the scenario. The studies and the data from the diagnostic errors that show us that there are 3 big disease sections that usually experience diagnostic errors. They are linked to vascular events, infections, or cancers. Now, we're not talking about very rare sort of vascular diseases. We're talking about common diseases like myocardial infarctions, strokes, VTs, pneumonias in terms of infections, common cancers, breast cancer, lung cancer. That usually should be diagnosed or being picked up early based on the screening and the guidelines that we have in the healthcare. So the common diseases are frequently missed more than what we may imagine in the healthcare practice. The diagnostic process, it really begins when the patient experiences a healthcare problem or symptoms, and they come in and engage with the healthcare system. Once a patient enters the doors of the hospital or reaches to the healthcare team, there are many different things that happen within the work system of the hospitals, right? We have diagnostic team members, we have tasks, technologies, organizational culture, physical environment, and many external influencers that come into play. There will be a lot of history taking, there will be data gathering in terms of exams, in terms of tests, a working diagnosis will be established, communicated to the team and among the team members, and the treatment will begin. And that treatment response may guide your further decision on the diagnosis. At the same time, the outcomes of this whole process are actually either accurate or timely diagnosis or a diagnostic error or near misses that happen. And they impact the patients. And ultimately, they impact the system level outcomes in terms of quality, safety, cost, and trust of the public on the healthcare systems. And ultimately, they provide us some learning opportunities from these diagnostic errors and the whole process to further improve the diagnostic process. If you look at the breakdowns in the form of a Swiss cheese model, which we commonly use in the patient safety science, to examine where in the diagnostic process the real failures happen, we see that there are a lot of missed opportunities to elicit or act upon key clinical findings in the form of history and physical examinations. At the same time, there is also overlooking of information in the medical records in the form of hypothesis and synthesis of the hypothesis, as well as tests and consults, and closing that loop of communication among the teams and with the patients and engaging them. So these are some common causes when it comes to the diagnostic errors. A lot of contributing factors could be there, which could be from language barriers, communication failures, biases, heuristics in terms of a team member being overconfident, and many different things can lead to diagnostic errors. But one very critical aspect of diagnostic errors that I really want to share with you today is about uncertainty when it comes to diagnostic science, right? It's an art. And really, you don't want to go for an under-testing or test somebody less, and don't order some tests that you may possibly misdiagnose. Or you don't want to be overzealous with ordering a lot of tests and resulting in maybe something that you don't want to find out in patients' disease process that is going on right now. And it's costly at the same time. So keeping that all the information in mind, let's jump to how we can redesign healthcare systems, right? And there have been recent papers published in this area, and one of them is by me as well, and recently from our CEO at Harvard Business Review as well, that we need to focus on systems rather than people in the healthcare, right? We need to provide them with the opportunities through better systems that they perform better and the outcomes for our patients are better. So the key components that we'll be looking at are, how do you promote patient-centered care? How do you look at teamwork and communication? What about cognitive biases and cognitive errors that happen as a result and lead to the diagnostic errors? How about looking at technology integrations? How do we develop a model of continuous learning and improvement in order to improve diagnostic safety and quality, as well as the process redesign? An excellent path or the path towards excellence in diagnosis is really defined by these four essential components, right? It uses fewest tests. It means that I'm not going to order a CT scan on everybody who walks into my clinic with headache, right? It maximizes patient engagement and patient experience. It also helps us manage and communicate uncertainty and provides us an opportunity to have that watchful waiting until we unfold the diagnosis in the patients. Leapfrog, which is a group in the US, and it provides a lot of accreditations and certifications in terms of patient safety grade to different organizations in the US, published some recommendations and best practices in the area of diagnostic excellence. And let's go through some of them. And at the level of organizational leadership and healthcare systems, their recommendations clearly state that the senior leaders are held accountable for diagnostic safety and quality as a part of the whole quality and safety plan and as a part of the whole quality and safety programs that they have. Hospital cultures support diagnostic safety and quality improvement and transparency. There are processes and structures in place to engage patients in their care, and as well as to identify the risks and hazards in the diagnostic process. And also it includes bringing in financial, technological, as well as staffing resources that are allocated to support learning and improvement activities. The recommendations in the form of the diagnostic process include that there should be processes and structures in place that allow to gather accurate and complete information for the patients, enable correct interpretation and synthesis of information, and effectively communicate diagnostic information to patients and ensure timely and complete handoffs and transitions of care. Let's look at culture in the form of improving diagnostic safety. The culture of fear and blame should be dived out, right? So that there is no one afraid to ask questions or diagnose them or share about their uncertainties with other team members about diagnostic process. Organization-wide commitments are required to improve diagnostics and learning from the delays in the diagnosis and errors in the process. Importance to respect human limitations, right? There is always an aspect of human factors, as we saw in the case that we discussed earlier, that the surgeon have had lack of sleep, there were some personal stresses, and there were many things that projected him into a failure that resulted in harm towards the patient. So we should also respect human limitations. And lastly, but not least, enhance the role of patient in co-producing diagnosis, right? There should be opportunities for patients to speak up and share their journey in their healthcare. They share their experience about their illness with the team so that the team can understand what is going on with their health problems. Compassion and empathy is the key in the area of culture, right? Among the teams, among the leaders, among the frontliners. And it's not just an amenity, but in fact, it is a good pillar. It's a pillar for good diagnosis. One needs to know that. Another aspect of diagnostic excellence that we were talking about is how do we enhance patient-centered care? The Barrel Institute recently have launched this concept of human experience in healthcare. Now, it's not just the interaction of patients with the healthcare systems, but also it focuses on healthcare workforce as well as the communities that they serve. And how do you bring it to practice? Let's think about patient and family advisory councils. If you have to do one intervention at the level of a leader in the healthcare systems, that really would be to enact and have patient and family advisory councils present in your healthcare systems, right? They are pretty low cost and low tech interventions and allows patients to come in and be part of the quality, safety, and improvement journeys that we have. Society for Improving Diagnosis in Medicine have a PFAC, which has come up with this amazing guide and provides a lot of recommendations how healthcare leaders and systems can enhance diagnostic safety by using PFACs. Another aspect of patient-centered care is to have strategies in place, have the systems in place that allow shared decision-making, that enhances patient satisfaction, have patient portals present, and we'll talk about patient portals in a bit, and then to target the health literacy of the patients as well. Communicate with patients about their problems in the language that they can understand. Also, there needs to be measures that needs to be integrated, such as patient-reported outcome measures and patient-reported experience measures. We commonly measure patient experience, and some of the aspects of patient experience that we can ask to the patients is how was their experience of their physician listening to them attentively, right? Physician sharing with them about their treatments and diagnosis. What about the teamwork? How do they think about the teamwork? A lot of research is being done currently in this area, learning from patient experience related to the diagnostic errors in order to advance the patient safety in healthcare. Also, we can use patients and have their panels come together through PFAC or other mechanisms across the country, across the different regions, in order to generate a priority list of the research work that can be done in the form of improving diagnostic safety. And some of the patient-selected priorities are really about my doctor should be communicating with me in a better way. They are about healthcare systems. Healthcare systems, patients are telling us what healthcare systems should do. They're telling us healthcare systems should have a way to track diagnostic errors and learn from them so that it is not experienced by the other people who come into that healthcare system later on after the visit. Another thing that we can do is to leverage patient-reported data. Open Notes is a US-based company and an intervention that is tested across various healthcare systems as of now. It allows the patients to have a look at their physician notes or their team notes from the nursing members. And patients can actually look into what my doctor has documented about me. And it provides them an opportunity to correct something if it's wrong, and to share something that has been missed with the teams as well. And a lot of organizations are leveraging it as a part of their electronic healthcare records. One example is to use such template into your Epic or Cerner or other kind of healthcare systems records that you have, or EHR systems that you have, in which you have a doctor's part, and then you also have a patient part, right? The doctor is mentioning about symptoms and doing their clinical workflow that we do as a part of our training and as a part of us reaching to the diagnosis. At the same time, we are also keeping into account how much our patient is informed about it, and also kind of like tracking the patient's symptoms, right? And engaging them together with us in order to co-produce the diagnosis for the patients and to improve the diagnostic safety as a result. At the level of physicians or clinicians or healthcare team members, these are very nice 5 strategies that could be easily integrated into the day-to-day practices, right? Seeking feedback on diagnostic decisions, right? Tracking patient outcomes, having that opportunity to be in touch with them, having those bite-sized practice. What do we mean by that? Having some learning material which is specific to certain symptoms or certain diseases, which keeps our information up to date, right? But not long lectures, but very small 5 to 10 minutes bite-sized learnings, right? Considering about biases, very important. We'll talk about biases in a bit. Making diagnosis a team sport where there is a role of patients who come in, and then fostering critical thinking, and we'll speak about it in a bit. Remember that as a part of the teamwork and communication, we have some evidence-based tools that are available and that should be implemented in different healthcare systems. And they help improve the transfer of information in the form of iPass or the SBAR or any other structured handoff things that we have that could be implemented and integrated with the electronic health records or electronic healthcare systems that we have. And at the same time, having those practices that influence of an interdisciplinary rounds or collaborative diagnosis where each and every team member shares their opinion openly and bringing them at the bed of the patient, right? And discussing those things in front of the patient in the inpatient setting will really help us improve the communication, teamwork, and ultimately the diagnostics as well. As I say, diagnosis is a team sport. This is what I mean by closing the loop, right? A lot of diagnostic errors happen in the ambulatory care settings or outpatient settings. And usually it is due to the fact that a primary care physician has referred a patient to a specialty clinic, right? And then the specialty consulting doctor orders some tests, reaches to some diagnosis, and just communicates that with the patient. And then things fall into the cracks. Nobody knows what happened next. In fact, that loop needs to be closed. There needs to be communication within the team members of the healthcare workers, right, from different settings, not just in the tertiary care, specialty care settings, but also within the ambulatory care or primary care settings, where we can keep all the team members informed about the patient journey and about the process where the patient stands as of his healthcare problems and his diagnosis. And then it can be communicated and taken into care by the primary care physicians. And this is pretty much what we mean when we talk about diagnosis as a team support and a closed loops in terms of communication. Remember, we speak about cognitive biases and cognitive errors. They really kick in when we are busy, as we always are in healthcare systems, and they also kick in when we are used to see the same things in again and again, because as physicians, we are trained as problem solvers. And then that links to some sort of biases, right? Anchoring biases or focusing on some sort of information that I have, and I'm focusing my whole diagnosis on it as a doctor. What about confirmation bias? Seeking information that confirms the initial impression that I had about a patient, that stops and blocks my thinking process, moving to the next differential that I may have in that diagnosis. What about availability bias? If I'm commonly seeing certain kind of disease, I will always think about that this patient may also have a similar type of disease, but that may let me miss if that patient have another form of disease. There could be some sort of bias mitigation trainings that may help improve diagnostic errors, but a very nice intervention that has been launched by Clinical Excellence Commission in Australia, as well as the AHRQ in the US, is about practicing a diagnostic pause. or in other words, we call it diagnostic timeout, right? You take 2 minutes and you think deeply about where it is and what is going on in terms of diagnosis. I'll give you some examples of it in the next slide. You look at it, you can ask these 3 questions, correct? You can ask about what else this might be, forcing you to think about more differential diagnosis. What doesn't fit well with this patient's conditions, right? Making sure that unexplained abnormal findings are not dismissed. What about what critical diagnoses are important that I should not miss? For example, aortic aneurysm or some sort of MI, stroke, on the list of the common diagnoses that I never should be missing, right? And those diagnostic pitfalls. These diagnostic pauses allow us to move to the system 2 thinking, right? System 2 thinking is about being more rational, being deliberate, being considerate about the symptoms and the findings, and then reaching to diagnosis rather than system 1 thinking process, which is automatic, on auto mode, and it's in our subconscious because we have been repeatedly seeing all those symptoms and findings, so that we'll just focus towards certain diagnoses rather than a whole bunch of it. To remind you that we only have about 200 to 400 symptom presentations, whereas we have about 10,000 diagnoses to look at, right? So there is a huge gap between symptoms and diagnosis. Not one symptom for one diagnosis. Usually, it's a long process. So this kind of diagnostic pause helps you in aligning yourself and reaching to a better diagnosis. What about technology integration? Today is the world of really advancements in terms of technology. Electronic health records have been optimized to reduce the burnouts, to make the physician entry systems easier. What about linking clinical decision support systems to them, such as Isabel, checklists, or Visual TX? These are some sort of applications that are very well known, and they are interoperable with the healthcare system, electronic healthcare records, and they help enhance diagnostic safety. Artificial intelligence in diagnosis also is really growing right now. It's pretty powerful, and we'll speak about it in a bit. And interoperability, as we talk about it, it helps us reduce the data between different errors that are related to data when transferring information from the lab systems to the electronic healthcare systems, or from the radiology systems to the electronic healthcare system. So all these considerations need to be paid towards different technology integrations that we have. AI in diagnosis, right? I would say be aware of it and beware of it as well. Machine learning has some potential in terms of predicting the risk of certain diagnoses based on the data that it has. It enhances our diagnostic process. Again, linked to what kind of data is added to it, right, in those algorithms. Computer-aided diagnosis is pretty promising as of now in radiology, in ophthalmology, in pathology. There have been a lot of studies recently claiming about the potential for them in order to enhance diagnosis. Patient engagement opportunities also exist with AI, right? When certain patients have certain sort of symptoms, we can put them on automatic tracks or some sort of patient portal linked algorithms, which will gather the information about patients' day-to-day progress, and also update at the same time the differential diagnosis list. Natural language processing is also important because it's helping us to extract a lot of information from the patient medical records, and rather than just reviewing them, in a manual manner. What are some of the concerns when it comes to the AI? It's about really what we put into it, and that is what we'll get out of it. It's whatever we will train it on, that will be the outcome of it. Enhancing the bias, it may enhance the bias if the data that is entered to it has bias and it has quality issues. It may lead to de-skilling of the physicians, which we physicians really worry about, and the healthcare workers also worry about. Again, there are issues in terms of privacy of data and security, and cybersecurity in healthcare remains a very big issue as of now. So those are some of the concerns. But the final verdict on AI and diagnosis from my side would be really, it's powerful and dazzling, but it's still not quite ready and can be potentially dangerous unless and until it's tested widely. And we know what it is that's happening when it comes to the AI and diagnosis. Thinking about continuous learning and improvement models, right? That's very important. When we have a whole system and we're trying to improve, we need to think about new care models. And these are called lead organizations, right? What are lead organizations? Leads are learning and exploration of diagnostic excellence. And these organizations or these care models are studied at the level of healthcare systems, right? And in terms of improving diagnostic errors, where you have an organizational hub and some place where there's somebody accountable for coordinating activities around improving diagnostic errors. And it takes input and outputs towards culture of engaging the patients and physicians and clinicians in order to improve diagnosis. At the same time, it links measurement for improving and learning from the diagnostic process. And also, it also links in it the researches and the latest evidence in the diagnostic practices that we have in terms of the guidelines. So that's some sort of a model that you may want to think about and how do you want to implement at your hospitals and in your healthcare systems. Nothing can happen without measurement, and you cannot really improve what you cannot measure. And National Quality Forum, which is a leading body in the US in terms of developing quality measures, have been working on linking some specific measures to diagnostic excellence for better healthcare. And their recent report, which is actually published in 2024 September, has presented a lot of diagnosis-related or diagnostic process-related measures and outcome-related measures. However, interestingly, the report still notes that there is a limited number of measures that are linked to patient-reported outcomes and the payments related to that. Right, so there needs to be still advancements and studies in terms of measures that are very specific to diagnostic processes, and that helps us as healthcare systems to learn more about the diagnostic process. When we think about process redesign, as I mentioned earlier, at every step of the process redesign, we have to partner with the patients, and patients can actually play a lot of role, right? You think about conducting a prospective risk assessment within the healthcare systems. Patients can help design those risk assessments. And I'll speak about one of the healthcare risk assessments just in a bit. Clinicians, right, working towards gathering and analyzing data for learning and opportunities that you may have. Policy and practice changes, taking actions and putting them into practices. Also creating and sustaining initiatives to learn, and patients can play a big role towards it as well by continuously engaging the healthcare systems. So as I speak about the good point for us as healthcare team members or healthcare systems or leaders, where should I really begin my journey of my hospital or my healthcare system to improve diagnosis is really to use this sort of a simple checklist called SAFER DX checklist. It's a risk assessment tool for healthcare organizations and systems. It has 10 questions, which are very high priority and can be linked to some sort of metrics that scores your healthcare system and hospital and provides you an opportunity to where to begin and where to focus your initial efforts within your organization as you move forward in improving diagnostic safety. Some final thoughts that I have are about the diagnostic process itself. The diagnostic process is pretty complex, right? But you need to know that it's always centered towards patient. All the information that's being shared, gathered, communicated, patient needs to be kept informed and engaged at the same time, using different technologies, using different sort of checklists, different sort of tools that we may have. At the same time, it's important to introduce diagnosis error-related measures, which are valid and reliable, and are forward-leading rather than just being retrospective. And this ultimately leads us to have that system of continuous learning and outcomes, which help us provide the feedback to improve diagnostic process. And if our outcomes are good and we are sustaining well, to bring changes in policy and practices to reduce preventable harm from missed, delayed, wrong diagnoses or overdiagnosis. Another final thought is that as you venture into future, right? AI is coming in, there's a lot of work going on in technology. please remember that it's always important to focus on human experience, which is really grounded in the lived realities of patients, families, and healthcare workers around diagnostic errors, and then integrate it with artificial intelligence and technological advancements in order to have a safer healthcare systems that help you reduce diagnostic errors. Some next opportunities and next steps that you may want to think about is how do you test and use novel methods to engage patients to improve diagnosis and reduce diagnostic errors? What opportunities you have to gather information from patients to learn about diagnostic risks and safety events in your organizations and in your healthcare systems? And what kind of tools and strategies you can put in place to achieve both of these goals? As I close my talk and as I speak about some of your implementation strategies or provide you some sort of an implementation roadmap, it's important to assess the current state of diagnostic process, probably using the SAFER DX checklist. Think about the culture of diagnostic excellence, as we spoke about it, redesigning the clinical workflows, integrate diagnostic pauses, integrate the clinical decision support systems, integrate advancements in machine learning and AI in an appropriate manner. Having opportunities to integrate technological solutions for patient engagement is another important thing. And ultimately, think about policy and practice changes at the national level, at the regional level, or at your healthcare system level that will promote diagnostic safety, probably linking to some new care models as we discussed, as well as possible payment models when it comes to the healthcare insurers and others who pay for the healthcare practices. With that, I would like to really show my disclosures and acknowledgements, and thank you all for your time to listen, and I'll open the floor for questions. Thank you.
Thank you very much, Dr. Mohammed. Amazing presentation. You really covered and touched on all the points that have to do with patient safety and diagnosis and errors. I thoroughly enjoyed it, and we have a large number of participants, national and international. I highly encourage everyone to write their questions in the Q&A. And while we wait for the questions, I just want to ask you a question. You mentioned the culture of safety at the beginning and effective communication. Now, we always say that, and it sounds easy, but it's not as easy as it sounds. So how can we ensure and emphasize this in our everyday work?
Right. Dr. Reem, this is one of the very important aspects of not only just diagnostic safety, but also the patient safety in healthcare, right? In practice, the culture is basically how we do things around here, right? In my organization, in my ward, in my department, in my healthcare system. And the tone is set right from the leaders to begin with, having some sort of policies in place, right? Thinking about just culture and just culture implementation policies, enhancing safety culture that you have in your organization, good catches and near miss rewards. All those are the activities that enhance the culture of safety. At the same time, introducing team steps and many other forms of interventions that you may have enhance the culture of safety, in which the physicians, the nurses, the healthcare team members, and also the patients feel empowered to speak up and share their experiences openly. So the culture really, if you have to summarize, it's about the leadership and how the leader sets the tone in the organization. And at the same time, it's about the frontliners, how safe they feel when they open up about the issues, how safe they feel when they share about the uncertainties in the diagnostic processes. And is there really a culture of blame and fear? What are we really learning from our reporting and error reporting systems? All that is what may help us enact and have a better culture of safety. One way is to have your patient and family advisory councils partner with your leaders to enhance the culture of safety, right? They should be your partner, not considered someone from the outside. They are actually part of the healthcare system. They experience what we give them in terms of treatments, when we show them when their journeys are, what's going on with them. So think about how we can also partner with the patients and enhance the culture of safety. Imagine a patient going to the frontliners and sharing with them a story about the case that they may have heard about in their PFAT meetings, where they describe about diagnostic errors and how a healthcare team member really intervened at the right time by speaking up. Is a great example of showing how shared decisions are made, how the organization respects the human experience in healthcare, not just the patient experience in healthcare.
Absolutely, absolutely. I agree with every word you said. Leadership support is, I think, a pillar that goes hand in hand when it comes to patient safety. We have a question here from Razan. How can we improve safe diagnosis if we don't have financial capacity to have a medical record system? I was about to touch on that also on one of my questions when it comes to the financial support or hospitals that don't have that kind of budgeting.
Right. If you see the interventions that I spoke about, you can actually use them in your day-to-day practices if you focus on your clinician tips that I presented and some other things. For example, PFAC does not require a lot of cost, right? It depends on how do you recruit the patient and family advisory council members. What about having and practicing diagnostic pause? I just gave you those 3 questions from the AHRQ's patient engagement and clinician engagement toolkit for improving. Practice that diagnostic pause. This does not require a lot of financial resource. What about working as team members and having that culture that enhance teams working together and closing the loop of sharing information among themselves and with the patients and documenting that properly? That does not require a lot of financial, efforts. Definitely, at the end of the day, there is also a recommendation towards technology and financial, security as well as stability required to enhance. But to work on the basics, it's about collecting the right data around the diagnostic errors, implementing certain practices in your day-to-day work that may enhance diagnostic safety. As some of the interventions that I've mentioned, they could be actually used in the paper-based medical records as well. How about you create a card and give it to the patients, right? This is what I, as a clinician, think about your diagnosis. Do you have any questions about it? Would you like to let me know more about it, right? What changed in your condition from yesterday till today? I'm not using any technology in that area. So there are some low-cost interventions present. The only way is to think about how I can fit them in my current practice. That is why I kept a lot of my interventions pretty universal for all of them.
Absolutely. And may I add the checklist that you mentioned in your presentation? That's a great tool for patient safety officers to use. There is a question here. What metrics do you recommend for tracking and assessing diagnostic errors, and how can we use these metrics to drive improvement?
Very nice.
That's a great question.
Yeah, thanks for asking this up. And as I mentioned to you, that the National Quality Forum has recently published in September 2024 a version on diagnostic measures, right? Diagnosis-related measures. Think about diagnostic errors and the harm as at the grand level that you have as the major outcome, but also need to integrate process measures. Okay, what about following the right screening methods in order to prevent the delayed diagnoses of the common treatable cancers? Okay, what about using proper measures in terms of the AMIs or myocardial infarctions and strokes in order to worsen the condition of the patient and come up with the diagnosis earlier? All those things can be used. So you can link to individual disease or individual common diseases that you see in your setting. A good point to begin would be to think about the top 5 diagnoses that you have in your healthcare practice. All right. And it's also an efficient way to think about it. And then link some sort of diagnosis process related measures to that. Also, you have measures in terms of patient experience. right? My doctor was listening to me. How was my perception as a patient about the teamwork among the teams that were there? Were I given proper discharge instructions? What about my doctor explaining to me about my diagnosis and process? These could be your process measures and could be your experience related measures. And at the same time, you can also use at a higher level some adoption measures. How integrated is your healthcare system's electronic formats, right? What sort of financial resources do you dedicate to them? What is the grand outcomes when it comes to diagnostic errors? And collecting that data is very important. And you can leverage your error reporting system for that. And a lot of the time, you need to also think how you can leverage the malpractice claims that come in your system in order to collect more information about the diagnostic errors. And you'll be surprised when you start to measure, you'll be surprised that even in the common diseases, you have a lot of things that may be missing.
Thank you very much. There's another question. Someone is asking in the Q&A, and I also had this question. How do you see the role of artificial intelligence and machine learning evolving in assisting clinicians with diagnosis and reducing diagnostic errors? What are the limitations and risks of relying on these technologies?
Right. I think this is a real timely question as we move into advancements in technological world. Artificial intelligence is pretty powerful, right? But we need to first see how effective it is in helping us improve diagnostic safety. You may have a lot of studies coming in JAMA, in many different kind of NEJM and other journals recently published that artificial intelligence-based system is performing better than a doctor, or it's more higher quality and engagement and all that. But how valid is that? Is it extrapolated across all the healthcare systems, across all the settings? Does that mean that the same artificial intelligence process that's being used in the US or in China or in Japan or in Australia or in a low-cost setting is also effective in Saudi Arabia and others? That's the first thing to think about when it comes to the artificial intelligence. I'm in support of enhancing the artificial intelligence and the work that's happening in this area. However, one needs to be pretty mindful of it. Artificial intelligence provides us a lot of opportunities. You can predict somebody's diagnosis earlier. It can help you to come up with a better lists of differential diagnoses. It can also help you in providing opportunities to engage patients more, right, based on tracking of the patient's symptoms. What about reducing the workload on the clinician, having those ambient AI-based scribes, which are just hearing your conversation with the patient and taking down those notes so that you can focus more of your attention towards your patient and listen to them more carefully and have that patient and doctor trust level that can come in. So there is an immense potential in this world. It's pretty powerful, it's dazzling. But one needs to be aware as well at the same time that there could be issues with security, with the privacy, with tons of biases that may be included in the artificial intelligence. And we have a body in Patients for Patient Safety US, where I'm also a champion member, and we're working on some sort of alignment currently in terms of recommendations to the national offices, where we are thinking about how artificial intelligence can help us improve patient safety, and at the same time thinking about those risks that occur in patient safety. So I would say it's a pretty timely question to ask. There's a lot of potential in that area. However, it needs to be checked, reviewed, and then implemented before being generalized to everybody.
Absolutely, absolutely. There is a question, maybe a bit off topic, but any advice for a fresh graduate who wants to start working in quality and patient safety?
Right. I mean, again, if I remember, the patient safety curriculums are already being incorporated into the medical education and into the trainings. 20 years before or 30 years before, these things were not available and they were not part of the medical education curriculum as well. So I am impressed by the fact that the young graduates or the current medical students are also thinking about safety and quality in healthcare, rather than just thinking about, what kind of physician I'm going to be and which specialty I'm looking at. So a good point for you to start is to really participate in those monthly M&Ms that happen in your setting, in your departments, in your divisions, and then present those cases and have that culture develop among your colleagues in terms of coming up with some sort of initiatives that may help you improve the safety and quality in the setting where you're working. And then you may learn with your experience that you will find a lot of people in this community of quality and safety to help you out as well, right? It's not you just alone. Today in this webinar, we have a whole community of patient safety advocates who are joining us together. So we all are with you on this journey, and there's a lot of help available. There are a lot of resources available in quality and safety when it comes to enhancing your understanding of quality and safety, as well as your work in the field of quality and safety. And at the same time, keep into your practice, right, those principles. If you could imagine those 5 tips that I have for clinicians, you can start practicing them from tomorrow, right, as a part of your medical residency or your internship that you're doing. Think about, did you do that diagnostic TMPOS? Did you reach out to different referrals? What happened with the list of your differential diagnosis? This is also going to help you learn and improve your training, and at the same time, improve the diagnostic safety. And you may keep account of those things as you move forward. Something interesting for you to work on.
Thank you very much, Dr. Mohammed Abid, for addressing this very interesting topic. On behalf of the Saudi Patient Safety Center, we'd like to thank you and the audience for their active participation. As part of the Saudi Patient Safety Center's efforts to provide you with timely topics and interesting speakers, we'd appreciate it if you would fill out the evaluation survey sent to your emails after the session. Thank you to the Saudi Patient Safety Center also for giving me this opportunity to be here and to moderate this session. We look forward to welcoming you all back in future webinars. Thank you very much.
Thank you very much, Dr. Reem, and the whole team at the SPSC, all of you for your time in improving safety. Take care.